Almost everybody's back gets better. Not everybody, but it's the same.
Yeah.
They'll say, well, you better go on some anti-inflammatories and do all of this. And you say, you know what, it just takes time.
Yeah. And
depending on what you have.
No.
But it usually just takes time. So you can do acupuncture, do everything and try and ease it, but probably just time.
Yeah. And it's sort of the tincture of time. And it's actually why in the medical field we believe things work so much better. Because if you have a condition, and then you treat it, and then you get better, it's hard for us as health professionals or patients to go, it wasn't that.
Right.
Because it's that time sort of concept where you go, it must have been that, when in fact the vast majority of things get better over time.
If you look at dosage, high dosage, low dosage,
Right.
how much of this do I need?
Right.
What questions do you ask?
Well,
your doctor tells you one thing.
Yeah.
The clinical trial says.
So one of the things that myself and my colleague published an article about a year ago about the whole concept of low dose. And in fact, if you look at the CPS is that big blue book that the doctor has with all the doses in it. If you look at the evidence, most of the doses in that book they're not completely wrong, but they're much, much higher than they need to be. And it may be one of the reasons why we had a problem with HRT, is that we used much, much higher doses.
Okay.
Because to get a drug on the market, you actually have to study a dose that's too big for most people. Otherwise, you can't show it works. So one of the key messages we try to get out about using medications is, especially if it's a symptom. So if you had a symptom of something, I would say the best dose for you is somewhere between 0 and whatever the upper limit is. And the only person, not your doctor, the only person who can figure that out is you. And so I would engage you in that discussion process because it's your body, it's your pain or whatever it is. I want you to figure it out and then tell me. So you're the experiment and you're going to tell me exactly how well it worked because that's the only way you can do it.
And does it make sense to start low? Aim high. You know, you don't want to get higher. So why don't you have just a little bit of the thyroid hormone or whatever? And if that regulates you, hey.
No, exactly. One of the things my students always get a kick out of it, I always say, the very first thing you should do is, when you get a prescription, is just look at the bottle for about a week. And then open it and just get the essence of it, and then lick a tablet, and then
see what happens.
See what happens. But really, in essence, the recommendation, especially for new medications, is unless you're going to die tomorrow, there's really no reason to start with more than maybe a quarter of a dose, and even sometimes an eighth of the dose that's recommended, because there is no way to predict how you, as a patient, would respond. You
did a really interesting podcast on antibiotics.
Yes.
I don't think there's a doctor around who doesn't say, if you take an antibiotic, you have to take them all or it won't work.
Yes. There's really no good evidence base for that.
That's shocking.
I know. I mean, it's almost a sacred
We're so
sacred
diligent.
cow. Yes. So we put that sticker on the bottle, and really now, for some infections, it's probably true, but for the vast majority of infections, things like, if you get a soft tissue infection or a skin infection, or if you get a respiratory tract infection or a bladder infection or so on and so forth, really the best evidence is that what you do is you take the antibiotic till you felt better for about sort of 48 to 72 hours. So if you no longer have a temperature and you're feeling better,
and you're not peeing every 2 seconds.
Exactly.
And all of that. So
then you can
check
stop.
Your body.
Yeah, because just so you know, the dose and actually the duration is kind of made up anyway because we use 10 days. And why do we use 10 days? Because it's a round number. You would never get. Have you ever had a prescription for 9 days?
No.
No, because it just doesn't make sense. But then, and 8 doesn't make sense, but 7 does. 6 doesn't, but 5 does. And so it's a very sort of a routine way of doing it. And so, there are certain infections, like if you have a heart infection, if you have a bone infection, you do need to treat those for an extended period of time. But for the vast majority of infections, the best available evidence, it's not perfect, is that what you do is once you start to feel better, and for 48 to 72 hours, and then you stop it. And the reason you do that is because if you think about it, the longer you're on an antibiotic, the greater chance of resistance. You don't have to get rid of every bug in your body. No. What you want to do is, when you have an infection, you have a certain amount of organisms, and you want to shrink it down and let your own immune system figure it out.
That's why we're taking all the acidophilus and building up all of that while we're taking this to cure that and do all of that. I do have a doctor who says, you have a virus, you do not have a bacteria, you don't need antibiotics.
Good.
That's good.
Yes, no,
you
absolutely.
Think, oh, but I've got this horrible cold or whatever I have. She says it's a viral something, that this won't help. Go home, take chicken soup.
Yeah, and especially with antibiotics, there are side effects. you can get skin rash, you can get diarrhea, and there are long-term consequences sometimes from taking antibiotics. So it is a balance, but in defense of people who do use antibiotics, it is tricky because we can't definitively rule out that it's a bacteria. And so one of the best ways, and we published this in the BMJ just I think last month, is to give what we call a delayed antibiotic prescription. So you could say, if you came in to see me with a respiratory tract infection or a bladder infection, you could say, okay, I don't think it is, although if it's a bladder infection, it's probably bacteria, but you might go, I don't really know. We think it might be a virus, but here's a prescription. If you're not better in 24 to 48 hours, go fill it.
Sure. And, we always pop on a bandwagon. For a while, everybody was popping niacin.
Right.
I have a friend who got gout, and he's popping niacin.
Yeah.
He said, do you know that's the worst thing I could be doing is niacin for gout? Because there's so much going on.
Right.
Where you look at things like osteoarthritis, injections, you did that in a podcast, overactive bladders, what to really do, vinegar and weight loss.
Yeah, no, yeah.
And migraines and steroids.
Yeah, and so what we want to do is just, I think health professionals, and even more so the patients now, need to be familiar, or at least have an idea of what the information says, because otherwise, how can you make up your own mind? Because it's really not your doctor's decision about whether or not you go on drugs. It should be yours. And to do that, one of the most common things I hear about why are you on a medication is, well, because my doctor thinks I should be on it. Well, that's not the right answer for why you're on a medication.
So you're talking about rational use.
Well, rational use,
but questioning your doctor, maybe, not defying your doctor, because
no, not at all.
Some drugs
you got to work with them. You work with a healthcare professional, but if their values and preferences are different than yours, maybe you would make a different decision. Because remember when we started off, I mentioned 2%. You said that's not very big. Well, some people think it is.
Oh, see, I don't.
Exactly. So, but if you don't, then maybe you wouldn't choose the therapy. But if I know people who said, I will do anything to reduce any risk, no matter what it is.
Okay, then that's personality driven, personality medicine. It makes so much sense.
Yeah. But the guidelines that are out there for blood pressure and cholesterol and so on don't actually talk about patient preferences.
See, that's interesting, because the good cholesterol, the bad cholesterol, and then what we're really looking at, according to my doctor, is the ratio. So if you have fantastic good cholesterol and a little bad, it's not the end of the world.
No, and well, here's where it gets really interesting with cholesterol is there's about 7 or 8 different types of medications you could take to lower cholesterol. Only one has ever been shown to reduce cardiovascular disease. Now you mentioned...
Great.
Yeah. So, but that's...
It's like heart bypass. Doesn't lengthen your life, takes the pain away.
Well, but if it takes the pain away, at least it does something. But with cholesterol lowering, we know that the statins, a group of drugs called the statins, reduce cardiovascular disease. Because it's not that you, again, it's not that you want to lower your cholesterol. You want to reduce your chance of cardiovascular disease. So how do you best do that? And in fact, we have to keep reminding patients, it's not about the numbers, because you get hung up and struggle with, well, if your blood pressure is 141/91, just breaking that threshold. We don't want people to worry all the time about that, because
that'll raise your blood pressure.
There you go.
Dr. James McCormack, I thank you.
My
pleasure. We can find you online.
Absolutely.
At
medicationmythbusters.com.
Okay. Thank you. Nice to meet you.